Dr. Vasudha to impart her lecture on morphology and clinical significance of Caesarean section scars. She graduated in medicine in 2001 and has and masters from Andhra Medical College in clinical research projects, imaging of the adenomyosis in female infertile patients, and presented a lecture on 3D ultrasound scanning at annual conference hosted by the Obstetrics and Gynecological Society of Visakhapatnam, and presently consultant infertility specialist at Krishna IVF Clinic.
Good morning, everybody. Coming to my topic, morphology and clinical significance of Caesarean section scar. As the Caesarean section rate is increasing in the last few decades, the number of women with Caesarean scar is increasing. Caesarean section improves the neonatal outcome, but it is also associated with long-term complications like Caesarean scar pregnancy, dysfunctional uterine bleeding, chronic pelvic pain, apart from the well-known complications like pathologically adherent placentas and uterine rupture. The nomenclature to describe Caesarean section scars examined using ultrasonography has been very recently published in the journal Ultrasound in Obstetrics and Gynecology in the month of August. The first question is, can we see the scar? Yes, the scar can be seen on a routine two-dimensional ultrasound, better seen by a transvaginal ultrasound compared to a transabdominal ultrasound. It is usually seen as seen in this picture, it is seen as a dark line at the anterior wall of the lower uterine segment between the utrovesical fold of peritoneum and the internal cervical os. The first picture is a scar in an anteverted uterus, and the lower picture, scar in a retroverted uterus. The word niche has been coined to describe ultrasound appearance of Caesarean scar. Though better delineation is possible with three-dimensional ultrasound and saline contrast sonohystrography, because of simplicity, low cost and non-invasiveness, 2D remains the best modality. And the best time for scar evaluation is at least 6 months after the last Caesarean section. Not only can we see the scar, we can even measure it. Several measurements have been proposed, but out of all these, the thickness of the remaining myometrium over the scar has the best predictive value. It is otherwise called as the residual myometrial thickness. It helps in differentiating between small and large defects. A deficient scar results from poor healing. It can be identified on ultrasound by the presence of fluid within the incision site, or any large filling defect at the site of scar, or a gap in the anterior lower uterine segment myometrium at the site of prior Caesarean deliveries. And all deficient scars do not look alike. Semicircular and triangular shapes are more common, but shape doesn't have any relation with the incidence of complications. And in women with multiple Caesarean sections, we cannot count all the individual scars because the subsequent incisions might have been made at the same level as the previous scar site. And what causes a deficient scar? The cause is not known exactly, but deficient scars are commonly seen when Caesarean section is done in advanced labor, in a retroflexed uterus, and in case of multiple Caesarean sections. And a deficient scar tends to be at a lower position in the uterus compared to intact scars. And coming to location of the scars, usually in case of preterm Caesarean section, the scar tends to be at a higher level because the lower uterine segment might not have formed by then. In case of an elective Caesarean section at term, it usually lies midway between the utrovesical fold and the internal cervical os. Whereas in case of an emergency Caesarean section, it is slightly at a lower level. I shall now discuss some implications of a deficient scar and the role of scar evaluation. So one complication is Caesarean scar ectopic, which is one of the rarest forms of ectopic pregnancy. The first case of Caesarean scar pregnancy has been published in the year 1978. Since then, till 2001, only 19 cases have been published, but there is a substantial increase in the incidence in the last 5 years. The probable mechanism that explains scar implantation is that there is invasion of the myometrium through a microtubular tract between the scar and the endometrial cavity. And how to diagnose scar implantation? Most of these women are asymptomatic, or they might have minimal vaginal spotting with or without mild abdominal discomfort. Unless there is rupture, where the woman will have severe acute pain, profuse vaginal bleeding, or she may be hemodynamically unstable. Ultrasound with color Doppler is the best tool for diagnosis. And there are certain ultrasound criteria for diagnosing a Caesarean scar pregnancy. The endometrial cavity and the endocervical canal should be empty without any contact with the sac, and the sac should be located in the anterior aspect of the uterine isthmus, and there should be no defect in the myometrium between the bladder and the sac. It behaves more aggressively than a placenta accreta because of early myometrial involvement. And very few cases reported in the literature have progressed beyond first trimester, as all of them have been terminated at that period of gestation. If this pregnancy were allowed to continue into the second or third trimesters, there is a very high risk of uterine rupture, severe substantial hemorrhage, increased need for hysterectomy, causing increased maternal morbidity and loss of future fertility. Sometimes there may be bladder invasion by the growing placenta, or sometimes the pregnancy might grow towards the uterus, leading to placenta accreta. Very rarely, if the sac, after protruding through the scar, if it is still viable, can implant on other abdominal organs and can continue to grow as a secondary abdominal pregnancy. Because the condition is rare, there is no consensus on the management, but termination of pregnancy in the first trimester is strongly recommended. Conservative medical treatment with transvaginal ultrasound-guided local injection of methotrexate is the first line of treatment, but prolonged follow-up with serial beta-HCG titers and ultrasound is needed. So other conservative surgical methods like hysteroscopic evacuation and laparoscopic removal have been done by some people. Here the advantage is prolonged follow-up is not needed, but surgical expertise is very important. When there is rupture or the woman presents late, laparotomy followed by wedge resection of the lesion with simultaneous repair of the scar is needed. And when the bleeding is uncontrollable, hysterectomy can be done as a last resort. A Caesarean scar pregnancy needs to be differentiated from a spontaneous abortion in progress, from an intracervical pregnancy, and a intrauterine pregnancy with low implantation. And what are the future prospects of these women? Because prolonged follow-up is needed, and also the methotrexate levels might persist in the body for longer periods, future pregnancy is to be avoided for up to 10 months. And once she conceives, an early transvaginal ultrasound is needed to assess the location of the pregnancy, and close monitoring is mandatory for the rest of pregnancy, as there is risk for placenta accreta and uterine rupture. This is a case of Caesarean scar pregnancy managed at our clinic. She is a multiparous woman, gravida 3, para 2, live 2, with a previous history of 2 Caesarean sections. She presented at 7 weeks pregnancy with minimal vaginal spotting. On ultrasound examination, she was diagnosed to have Caesarean scar pregnancy. She was managed by transvaginal ultrasound-guided aspiration of the sac contents, followed by local injection of methotrexate. The second picture was taken on day 5 after the procedure. We can see the collapse of the sac with a small fluid collection at the fundus. She was followed up for the next 4 to 5 months with beta-HCG levels and ultrasound till complete resorption of the pregnancy. Now coming to another potential complication of Caesarean scar that increases maternal morbidity and mortality, scar dehiscence or uterine rupture. Till now we know that dating is very important for a post-Caesarean pregnancy to take a decision about when to plan delivery for that woman. But an ultrasound assessment of the scar between 35 to 38 weeks is equally important to decide the mode of delivery. If during this period the residual myometrial thickness is less than 2.2 millimeters, as we can see in this picture, the residual myometrial thickness is 1.9 millimeters. In such situations, it's always better to go for an elective Caesarean section. Some women with previous history of Caesarean section might present with postmenstrual or intermenstrual spotting. This abnormal uterine bleeding may be due to retention of menstrual blood in the scar defect, which is intermittently expelled, or due to in situ production of blood in endometrial stroma. Also, before planning thermal balloon ablation in women with previous history of Caesarean section, a deficient scar should be ruled out because there have been reported cases of visceral injuries due to passage of microwave energy through the thin myometrium. So in summary, examination of Caesarean scar should be routinely done, and if residual myometrial thickness is less than 2.2 millimeters between 35 to 38 weeks pregnancy at term, it is better to defer VBAC. And deficient scar can be included as a differential diagnosis in patients with dysfunctional uterine bleeding and a previous Caesarean section. But further studies are required to identify the factors leading to deficient scar, how to prevent a deficient scar, and how to manage it. Thank you. I thank